The next speaker will be Dr. Kyung-Seok Park, and I will probably no needs to have more introduction, but here we go. Dr. Park received his medical degree from Seoul National University College of Medicine in Seoul, South Korea. He was trained at the Department of Neurology, Seoul National University Hospital, and completed 1-year clinical neurophysiology / neuromuscular disease fellowship at the same hospital. Dr. Park has been serving at the neuromuscular division of Department of Neurology and also working as the director of a clinical and intraoperative neurophysiology at the Seoul National University Bandang Hospital. He is currently a professor of neurology at Seoul National University College of Medicine, and Dr. Park's main research interests include neuromuscular spinal disease and clinical neurophysiology, particularly intraoperative neurophysiology. He is the current president of the AOSIN, and he will now present a lecture on advances in intraoperative neuromonitoring during microvascular decompression for hemifacial spasm. Thank you, Dr. Park.
The title of my talk today is Advances in IOM during Microvascular Decompression for Hemifacial Spasm. I'm Kyung-Seok Park, working at Seoul National University Bandang Hospital in Korea. The objectives of my talk include to review the conventional IOM methodologies during MVD in hemifacial spasm, to understand new advances and updates for last 10 years, and to recognize the usefulness and their applications of the new advances to IOM practices. You can see for Caucasian, the prevalence is 7.2 per 100,000 population. For Hispanic and African American, 2.7. But for Asian, it is 12.6. As you can see, hemifacial spasm is much more common in the Asian populations. The possible cause is suggested as relatively smaller posterior fossa in Asian skull, resulting in more crowded neurovascular structures in CPA system, thus making vascular compression of the facial nerve more likely. So, the IOM of hemifacial spasm is much more important in Asian countries than other areas of the world. Main purpose of IOM during MVD for hemifacial spasm are to protect neural structures nearby, to optimize the effectiveness of MVD, to predict surgical efficacy or surgical outcomes, and to investigate the pathophysiology of the disease. Let me show you a brief and typical case. The patient is 38 years old male. Chief complaint was right side hemifacial spasm for 2 years. The arrow shows the offending vessel here. This slide shows electrode placements for lateral spread response LSR monitoring. Recording electrodes are installed in the frontalis and orbicularis oculi, orbicularis oris, and mentalis muscles, and stimulating electrodes are inserted to stimulate temporal or zygomatic and mandibular branches of facial nerve. This slide shows a baseline BAEP and free-running facial EMG. You can see LSR here in the mentalis muscle on the stimulation of temporal branch, and RSR in the frontalis muscles on the stimulation of mandibular branch. During the operation of normal tonic discharges in free-running EMG in facial muscles and latency delays of BAEP after Teflon patch insertion were observed. After Teflon patch insertion, LSR was disappeared in mentalis muscles on the stimulation of a temporal branch. The same result was shown in frontalis muscles on the stimulation of mandibular branch. At closing, BAEP amplitude and latencies were almost normalized, and the patient showed no hemifacial spasm post-operatively. This is a cascade view of the LSR monitoring. You can see the disappearance of LSR here. In 2012, Dr. Fernandez Conejero and her colleagues published a review article on intraoperative neurophysiology during microvascular decompression for hemifacial spasm. They reviewed extensively results of the researches until that time. They included 5 methodologies in their articles. AVR, auditory brainstem responses, which is the same as BAEP, brainstem auditory evoked potentials, LSR, and AMR. AMR is the same as LSR. AMR represents abnormal muscle response. Facial F-wave, facial corticobulbar MEPs, and blink reflex. ABR or BAEP is used to reduce risk of hearing impairment. There has been several warning criteria proposed. Polo et al. Suggested criteria based on delay in latencies of peak 5 as watching signal, a warning of real risk, and critical warning. For RSR or AMR, Dr. Moller reported its disappearance could be a guide to adequate decompression of offending vessel and prognostic factor of better postoperative outcome. However, possible discrepancies among decompression of offending vessel, disappearance of RSR, and cure of hemifacial spasm has been suggested. So, practical value of LSR disappearance as a method to evaluate MVD efficacy is still controversial. And in their review article, they also described facial corticobulbar MEPs. As you can see in the figure, it was reported either the number of stimuli and or stimulating intensity to generate facial corticobulbar MEP should be increased immediately after MVD. And it is presumably due to an immediately decrease in hyperexcitability of the facial nerve and or facial motor nucleus. The situation was quite similar for blink reflex. Either the number of stimuli and or stimulating intensity should be increased immediately after MVD. You can see the changes. And the underlying mechanism for this phenomenon would be presumably similar to facial corticobulbar MEP. From now on, I'll present advances of researchers after 2012. As for BAEP, in 2016, Dr. Ju and his colleagues published a paper on fast acquisition of BAEP. They studied waveform changes according to stimulating rate and number of averaging, and proposed a new protocol with higher stimulation rate and lower number of averaging, which could obtain a reliable result less than 10 seconds. The same research group reported a result of new analysis on warning sign. The authors analyzed the instance of postoperative hearing loss according to various combination of wave 5 changes in 932 patients. They found only a latency prolongation more than 1 millisecond, or only amplitude decrement more than 50% was not related to postoperative hearing loss, but loss of wave 5 and latency prolongation more than 1 millisecond with amplitude decrease more than 50% were highly associated with postoperative hearing loss. They also reported on the significance of wave 1 and found a patient group with a wave 5 plus simultaneously a simultaneous wave 1 loss. Was more closely associated with postoperative hearing loss and other otological complications such as dizziness and tinnitus. As for LSR, there has been a couple of quite important and interesting study outcomes. This study is a prospective design with 145 patients. The author compared a surgical outcome according to LSR disappearance and found LSR disappearance correlated with spasm-free status at 1 week postoperatively, but not at 1 year postoperatively, and concluded intraoperative LSR monitoring does not appear to correlate to the surgical outcome, especially in long-term time points. This is also a report of a prospective study on 100 patients, and their statistical analysis did not find a significant correlation between the relief of LSR and clinical outcome. There has been a report of a new methodology, so-called CL response. As a conclusion, the authors suggested this response was useful when the abnormal muscle response was absent before decompression or persisted after all vascular decompression were properly treated. Also, this response may help neurosurgeons determine the real culprit when multiple offending vessels exist. Next, research is on blink synkinesis and blink reflex were also published. Blink synkinesis refers to an abnormal synkinetic contraction of orbicularis oculi and oris muscles by stimulation of the supraorbital nerve in patient with hemifacial spasm. Taiwanese researchers compared NVD outcomes with blink synkinesis, LSR, and facial corticobulbar MEP in 65 patients, and they concluded blink synkinesis showed the highest sensitivity and predictive values among the 3 methods. As for blink reflex monitoring, let me show you a brief case. This patient is a 51-year-old female. Chief complaint was right side hemifacial spasm. You can see a vascular structure close to her right side facial nerve. This slide shows the electrode installation for blink reflex. needle stimulating electrode are placed on the bilateral supraorbital nerve, and the recording electrode were inserted in bilateral orbicularis oculi muscle. This is a slide which shows baseline lateral LSR, free run EMG, and BAEP. You can see blink reflex responses throughout the monitoring here, but it was disappeared suddenly during dura opening. LSR disappeared during implantation of Teflon. One interesting finding was the time point of disappearance between LSR and blink reflex was different. So my colleagues and I compared these two tests during MVD for hemifacial spasm in 41 patients. There were 4 patterns of disappearance, nearly simultaneous or blink reflex followed by LSR disappearance was most frequent in about 73% of patients. Blink reflex disappearance only pattern in 19.5% and LSR disappearance only in 2.4%. This is an illustrative case with blink reflex and LSR completely resolved after MVD. Here, here, here. And another case with blink reflex resolved after MVD while LSR persisted. You can see the disappearance of a blink reflex here, but LSR persists throughout the surgery. When you compare the two test result with clinical outcome at the time point 1 day, 1 month, and 6 months after operation, blink reflex result was significantly related with clinical outcome in all time points. But LSR result were significant only in time points of 1 day and 1 month, not 1 year, and not 6 months time point. The sensitivity and specificity of blink reflex were higher than those of LSR, especially at 6 months post-operatively. And conclusions was intraoperative blink reflex monitoring is a potentially useful tool to help facilitate an adequate decompression and is a reliable prognostic predictor of surgical outcome. And we published our result in Clinical Neurophysiology last year. This is a summary of my talk today. New protocol of fast acquisition of BAP were reported, which can obtain a reliable result in less than 10 seconds. New critical warning criteria of BAP was suggested through a reanalysis of conventional criteria. LSR result fail to represent a reliable prognostic indicator for clinical outcome, especially in long-term follow-up period. A novel ZL response was reported, which can be recorded by electrical stimulation to offending artery wall. Blink reflex and blink synkinesis monitoring might be promising candidates of new methodology other than LSR, not only to indicate an adequate decompression of facial nerve, but also to predict surgical outcomes. Thank you for your attention.
All right. So thank you very much, Professor Park, for your lecture on the hemifacial spasm, and great to see you again online. And we have some questions from the floor, and the first one being under rare circumstance, if there is no significant decrement of LSR or blink synkinesis after the Teflon decompression, what can we do to make sure if the decompression is adequate or not?
Yes, thank you for the nice question. In that, if you only monitor those two methodology, there is no way to check the adequate decompression in that situation. But according to the authors of ZL response, if you check it simultaneously, it may roll as methodology in that situation. But you should add that methodology
Right.
in that case. But as I mentioned in my presentation, it should be we should keep in mind that the disappearance of or existence of aerosol or Brinkley reflex is not always mean that the decompression surgery is not adequate. So so we need, if the surgeon is sure to decompress to the surgery correctly, then we can, I think, we can wait for a while. Okay, that's my question. That's my answer.
Right. Thank you very much, Dr. Park. And the next question, in your experience and study, and how long in average will you wait until the LSR or blink this kinesis disappeared?
Yes, this is another good question, I think. According to it's not my own, not only my own result or experience, but also many research results. So we should wait 6 or 1 year to evaluate the outcome.
Mm-hmm.
Personally, sometimes this is my personal experience. I sometimes check LSR in laboratory after surgery. One 1 week or 1 month or a few months later. And that result, this is not intraoperative result, but laboratory result. And that result sometimes give me some information about outcome or prognosis of the patient. The methodology, I mean, the methodology for RSR is somewhat different intraoperatively or a laboratory test, but it can help somehow.
Okay, but the question is really how long do you have to wait for the disappearance during the surgery? Yeah, just wondering how long would you wait for the disappearance during the surgery?
During the surgery?
Yes.
Oh, it depends. It depends. It depends on the on each surgery. But as I showed in my presentation, the disappearance time for aerosol and blink reflex, the time points are different. So I usually do not wait a certain time period during the surgery. I have no fixed time interval for waiting.
Right. So any questions from the floor?
Okay, I think we are going to end this section right now. And thank you for all the 3 speakers. And I'm so honored to chair this section with Professor Ye together. And don't forget that Professor Ye had another lecture at lunchtime. And we thank Professor Park for your excellent speech. Because that we are a little bit behind the schedule, so let's stop the section here. Is that okay for you, Professor Ye?
That's fine. I'm happy with that. So thank you very much, Dr. Yu, and to be the co-chair for this session. And yes, yep, happy to move forward to the next session. Right. Thank
Okay.
you.
So on the schedule we have a short break. So there will be a 5-minute break from now on. So don't forget to be back by 10:50. The time here. I think we're a little bit time difference among us. So 5 minutes later. Thank you.
Thank you.
Thank you.